Right. Any questions or any doubts, or shall we move on to the next topic?
Yes, sir.
Mhm.
Good evening, sir. My
Good.
topic for presentation today is physiology and pathophysiology of liver. Functions of liver. Liver is involved in the coagulation process, synthesis of procoagulant and anticoagulation factors, and in protein synthesis like albumin and clotting factors like 2, 5, 7, 9, 10, 11. And it is involved in drug metabolism and in metabolism of carbohydrate, protein, and fat molecules. And it is involved in bile production and regulation and bilirubin metabolism. And it is helpful in storage of fat soluble vitamins. And it is mainly involved in uptake, storage, and release of the blood glucose. And liver is also involved in detoxification of drugs, ammonia, and toxins. And liver also has an immunological role where the Kupffer cells, which is a type of macrophages, which remove the pathogens, and it is also involved in thermoregulation. And regarding the histologically, the liver parenchyma is divided into anatomical units called the hepatic lobules, which is the basic structural unit, which is hexagonal in shape. And the functional unit of liver is the acinus, which is the smallest unit of the liver where the acids is formed by the portal canal at the center and the hepatic venule at the periphery. And the portal triad is bile ductule, hepatic arteriole, and portal venule. And oxygen and nutrient-rich blood from the portal triads through the sinusoids, they enter the central hepatic veins. And liver sinusoidal endothelial cells, they have the fenestrations up to 50 to 150 nanometer in diameter. They allow the passage of metabolites, plasma proteins, and lipoproteins and other solutes into the space of Dizzy, which is the space surrounding the sinusoids, while retaining the blood cells and vessels. And larger macromolecules and immunogenic peptides pass through this sinusoidal endothelial cells by transcytosis into the space of Dizzy, and these molecules are taken up by the hepatocytes. And the hepatocytes form up to 75 to 80% of cellular volume of the liver, and the basolateral portion of the membrane is in direct contact with the space of Dizzy, and the apical portion drains bile into the ductules. There are three zones where the periportal zone, which is the major site for aerobic metabolism, glycogen synthesis, and sulfation. And second one is the middle zone, which is around the central vein. And the third zone is perivenous or pericentral, which is the major site of hypoxia, anaerobic metabolism, glycolysis, and glucuronidation. And regarding the immunological role, the residual immune cells are present in hepatic stellate cells, which resides in space of Dizzy between the sinusoidal endothelial cells and hepatocytes. They are in the quiescent state in normal liver. They activate in liver injury. And myeloid cells give rise to Kupffer cells, which is a resident type of macrophages, which resides in portal and lobular liver sinusoids, which engulf the infectious and non-infectious particles by phagocytosis. And the cells of lymphatic origin are natural killer cells and mucosa associated invariant T cells and gamma delta T cells, CD8 plus T cells, and B cells, which are involved in innate and adaptive immune response. And regarding the blood supply to the liver, they form 25% of the resting cardiac output, and it is formed by the hepatic artery and portal vein. Hepatic artery formed up to 25% of the flow, and portal vein form up to 70 to 75% of the flow. And the remaining blood supply from it is from the superior mesenteric artery. And the hepatic artery, which gives rise to common hepatic artery, and in turn gives rise to gastroduodenal artery, which enters the hilum and divides into right and left hepatic arteries, which enter the hepatic sinusoids. And in the portal vein, which receives oxygenated blood to the liver. And the portal vein, it receives its supply from GIT, pancreas, spleen, and also through these veins, uh, gastric veins, cystic, pancreatic duodenal veins, they enter the hilum and they divide into the right and left hepatic veins and through the hepatic sinusoid and ultimately drain into the IVC. And regarding the control of liver blood flow, there is a hepatic arterial buffer response, which is the ability of the hepatic artery to adjust its flow inversely to changes in portal venous flow, thus maintaining the hepatic blood flow to constant delivery of oxygen. If its clinical significance is that if portal blood flow increases, adenosine washout is decreased, and adenosine ideally accumulates and results in hepatic arterial vasodilation. And inverse occurs if there is increased hepatic arterial blood flow. And portal vein has only alpha receptor, and hepatic artery has alpha and beta receptor. And regarding the pathophysiology of liver, and liver is injured, chronic hepatic injury occurs via alcohol, viral hepatitis, and non-alcoholic steatohepatitis and toxins, which ultimately leads to hepatocyte necrosis and inflammation, fibrosis, and which in turn leads to fibrosis and nodular regeneration, which leads to distortion of the hepatic architecture, which in turn leads to increased intrahepatic vascular resistance, and ultimately results in portal hypertension and hepatocellular dysfunction, leading to the multi-organ dysfunction. And regarding the portal hypertension, which where increased resistance to portal blood flow by fibrosis or nodules, in turn increases the portal venous pressure, resulting in the development of collaterals, leading to esophageal or gastric varices, and leading to splenomegaly, which in turn leads to thrombocytopenia and ascites. And regarding the mechanism of ascites, where increased portal pressure and decreased albumin, which in turn leads to decreased oncotic pressure, and also there is increased aldosterone and ADH secretion, which leads to the sodium and water retention. And regarding cirrhosis, there is there are two types: compensated and decompensated, where the compensated cirrhosis in turn leads to the loss of functional reserve, which in turn leads to the portal hypertension, ascites, and varices. If it ultimately leads to the development of encephalopathy, hepatic renal syndrome, and jaundice, ultimately results in decompensated chronic liver diseases. And regarding the uh, other changes, specific changes, the hepatic metabolic dysfunction occurs, wherein carbohydrate metabolism, there is decreased glycogen storage and gluconeogenesis, which ultimately leads to hypoglycemia. And regarding a protein metabolism, where there is decreased albumin levels, where in turn leads to decreased oncotic pressure and edema is most common. And regarding lipid metabolism, there is altered synthesis of lipids, which will lead to fatty acid infiltration. And there is a synthetic dysfunction of coagulation factors. And also there is due to decreased albumin, there is altered drug binding. And due to detoxification failure, there is accumulation of ammonia, mercaptans, and short chain fatty acids, ultimately in the brain, leading to hepatic encephalopathy. And due to impaired drug metabolism in liver injury, there is a prolonged action of all the anesthetic agents. And in portal hypertension, there is due to increased resistance in portal blood flow, and collaterals are formed. Bleeding risk is increased due to the gastric and esophageal varices, and around and also due to ascites, there is decreased functional residual capacity, and there is a difficult ventilation. And regarding the hemodynamic changes, there is hyperdynamic circulation in the heart, where there is increased cardiac output and systemic vascular resistance and arterial pressure, and there is blunted baroreceptor and beta adrenergic response, where there is poor response to stress and anesthesia. And diastolic dysfunction and QT prolongation is most common. And regarding respiratory system, there is ascites and pleural effusion, which in turn leads to the restrictive lung pattern. And hepatopulmonary syndrome, which occurs due to intrapulmonary vasodilation of due to shunt vessel formation, which ultimately results in hypoxemia. And ultimately, other complication is portopulmonary hypertension, where the pulmonary vasoconstriction is most common, which in turn leads to the right ventricular failure. And regarding renal system, hepatorenal syndrome, where the functional renal failure occurs due to splanchnic vasodilation and renal vasoconstriction, which occurs without the structural damage. And there are two types where the type 1 is rapid and severe, and the second one is slow and chronic. And there is decreased GFR and sodium retention and impaired drug excretion is most common. And in CNS, hepatic encephalopathy is most common, where due to GABA accumulation and ammonia, where ultimately leads to confusion and coma. This can be precipitated by infection or GI bleed or electrolyte imbalance. And the hematological changes are anemia, thrombocytopenia, and coagulopathy, and ultimately other resulting in DIC-like picture. And electrolyte and metabolic abnormalities are also most common, which are hyponatremia, hypokalemia, hypocalcemia, and hypomagnesemia. And regarding the drug metabolism, will be the decrease in phase 1 and phase 2 reactions in the liver. And in regarding the alcoholic liver disease, first the fatty liver, which is the otherwise known as steatosis, which is the reversible form of liver disease, where abstinence from alcohol can uh, further stop the progression of the disease. And the fatty liver in turn can lead to steatohepatitis, and the steatohepatitis in turn can lead to cirrhosis. And if left untreated, it can even lead to decompensated cirrhosis and further complications. Thank you, sir.
Where did you prepare this answer from?
Sir, actually, half from Miller's, half from Robbins, sir.
Okay. So in Miller, there is volume 1, they give a entire chapter which is named as Physiology and Pathophysiology of the Hepatic System. Could you go through the title of that chapter? So it is mentioned like that, Physiology and Pathophysiology of Hepatic System. And the questions that I have been giving you are all questions recently asked, which have been sent by Dr. Kamati to me in various universities and MD and DNB exams. Okay? And somebody has cleverly picked up this particular topic to find out how the students have understood the hepatic system by asking this question, straight away taking the title of that topic that is given in Miller, volume 1, which is basic sciences. Okay. So when you talk about pathology, the abnormal pathology only becomes a pathophysiology as far as liver is concerned. Okay. So the normal physiological functions of the liver, you are straight away starting with coagulation proteins and coagulation factors. But the primary function is metabolic activity. Okay.
Yes, sir.
Liver is our metabolic storehouse. So the description of the protein, carbohydrate, and lipid metabolism has to be dealt with in little more elaborate when this question is asked as given in Miller itself. Then you talk about bilirubin metabolism, then you talk about coagulation factors, then you talk about the immune function of the liver, and also finally you have to say that liver is one of the important reservoir of blood, isn't it?
Yes,
What
sir.
is the reservoir function it can do? When there is a trauma and you lose up to how many ml of blood can be transferred to the systemic circulation from liver? Any idea? From this splanchnic circulation, which includes liver, spleen, and the other intestines, how much of blood can be transferred from these organs by squeezing the blood that is present in them into the systemic circulation to maintain the normal cardiac output and oxygenation of the tissues? Any idea for anybody can answer that? Up to 1 liter it will be able to supply. Okay. So that is how our body compensates in acute trauma. You don't immediately become hypotensive, even if you have a bleed. Okay. So only when the compensation or the contributing factors moves after the supply, also you continue to bleed, then you become severely hypovolemic and hypotensive. But in the initial contribution, blood as a reservoir for a blood bank for our body is a very important function that also is part of the physiological process. Okay. And when these physiological process go haywire, then you develop jaundice is one of the important pathophysiology that will happen in the liver diseases. Cirrhosis, portal hypertension, esophageal variceal bleeding, and consequent to portal hypertension and cirrhosis, renal involvement, which all you beautifully described, all the pathological conditions you described very well, and coagulation abnormalities also can set in. Okay. So you have to concentrate a little bit more on your, you don't have to waste your time writing about the individual functional unit of the liver like acids and hepatocytes and the space of BC, the blood supply, the hepatic renal arterial buffer and all those things that portal and hepatic arterial buffer system, all that is not very much required because they are all more of anatomical points. So in physiology, you have to concentrate on the functional status of the liver. Okay. So with that slight modification, I will just show how to deal with that particular question.